Assalamu alaikum wa rahmatullahi wa barakatuh. Today we are going to talk about lung cancer in general. My name is Maen Hussein, medical oncologist, hematologist. You can see my email here, mhussein@flcancer.com. If you have any questions, you can always email me. I'll be happy to answer any questions. So lung cancer is divided into two main types. The non-small cell lung cancer, it's around 80 to 85% of all lung cancer and has three major subtypes. The adenocarcinoma around 60%, squamous cell carcinoma around 30%, and large cell carcinoma around 10%. There is also the undifferentiated, which is kind of uncommon. In the past, we used to have more squamous cell cancer, but now with the less smoking, not as many people smoking, we're seeing a resurgence of the adenocarcinoma type. The other type is the small cell lung cancer. It's around 15%, which is a form of neuroendocrine tumor. It's a high-grade malignant neuroendocrine tumor. Usually grows more rapidly, metastasizes more rapidly than non-small cell lung cancer, and diagnosed in smokers or patients who are previous smokers. Around 98% of cases are attributed to smoking. شوية history عن lung cancer. In the 40s, 50s, actually doctors used to advertise for smoking. As you see here, like more doctors smoke Camels than any other cigarettes, which is one of the bad ones لأنه ما فيهاش فلتر حتى الكامل يعني. In the 50s and 60s, studies started to show that smoking is a major cause of cancer, mostly in the 60s and particularly lung cancer. By the early 60s, the US Surgeon General, UK Royal College of Physicians, issue reports linking smoking to cancer and other serious health problems like heart disease and emphysema. So now we know the relationship. Now there are less smokers. مشان هيك we are, like I mentioned before, we see more of the adenocarcinoma. In 2010, screening for lung cancer was approved. In breast cancer we do mammograms. Lung cancer we didn't have very good screening tests. There were trials with chest X-ray, but this didn't show much benefit. But then the National Lung Cancer Screening Trial compared CAT scan, which is a low-dose CAT scan, with the chest X-ray, and it showed a 20% decrease in mortality in heavy smokers if they're screened annually, so every year for 3 years. And this trial did show benefit in mortality reduction. واحد من 5 you can save if you do lung cancer screening. The US Preventative Service Task Force give it a B recommendation for those at high risk. And actually the Center for Medicare, which is kind of the general insurance for patients over 65, and Medicaid services, people who are poverty level, had agreed to cover the cost for screening. The recommendation is for patients from 55 to 77. Patients who have, they should have a 30-pack year smoking history, or if they quit, they have quit within 15 years. فإذا واحد كان يدخن وبطل دخان أكثر من 15 سنة, they don't get the screening. That's now becoming standard of care. And again, it can reduce the mortality of lung cancer. Symptoms of lung cancer before we go to treatment, usually, cough, shortness of breath, unfortunately, hemoptysis, which means coughing up blood. Unfortunately, most of the time, when patients have symptoms, it's at advanced stage. Mechanically screening is very important. Usually patients already have like weight loss and no appetite and, the shortness of breath. The patient with lung cancer could have emphysema, so sometimes it's hard to relate the cough and shortness of breath to lung cancer. What are the treatments of lung cancer? It depends mostly on the stage and the type of cancer, which means histology mainly, and now we also do genomic testing. We'll talk about that a little bit. Of course, the general health at the time of diagnosis, if the patient can't tolerate surgery or they can't, then you can do other modalities like chemoradiation or even chemotherapy. So part of general health is looking at the health history, like other medical conditions or what we call comorbidities, like COPD, heart disease, diabetes. Age doesn't really matter. It's more of like the general health and the health history. You could have a 50-year-old who has severe COPD, and you can have an 80-year-old who is healthy otherwise. And usually the 80-year-old could do better than the 50-year-old at this case. Goals of treatment, curative versus palliation. When we talk about palliation, we mean like relieving symptoms. So we don't cure the disease. Cure is when we take it out mostly, or sometimes we do stereotactic radiosurgery, which is a focused localized radiation to the tumor. It's very important. This cancer is usually a team effort. It's not just a one doctor disease. It's a team of doctors. So you need to talk to experts when you treat lung cancer. So you have the medical oncologist, which the ones who give the chemotherapy, targeted therapy. You have the thoracic surgeon, pulmonologist, the lung doctor, and radiation oncologist. You can also include nursing staff, nutritionist, and even genomic or molecular biologist. So we'll start with the non-small cell lung cancer. That's the most common one. The treatment options, if it's an early stage, like stage 1, sometimes 2, even at stage 3A, if the patient can tolerate surgery, we do surgery. So they will perform what we call pulmonary function test, see if they can tolerate the surgery, cardiac, check the heart condition, and then we can go for surgery. We can actually sometimes even give chemotherapy and immune therapy before the surgery to shrink the tumor. And sometimes we do chemoradiation, and we can follow that with surgery. It's not common though. The second modality is radiation therapy. Radiation therapy could be combined with chemotherapy, could be without chemotherapy. And sometimes we could do what we call stereotactic radiosurgery. So it's not really a surgery, it's a form of radiation that you localize or focus the high concentration radiation to the tumor, and you can do it actually over 5 days. Systemic therapy, it's for mostly patients who are not candidate for surgery or even localized radiation, like stage 3B and 4. And that includes chemotherapy, and there are different combination of drugs. Targeted therapy, we'll talk about that, and then we have the immune therapy modalities. So surgery, if your cancer has not spread, if the cancer has not spread to other places in the body, the doctor can recommend surgery to remove the tumor as a first option. You can do wedge or segmental resection, which you only take the small part of the lung that has the cancer. You can take the whole lobe, and we try to avoid this, but you do pneumonectomy, which means you remove the whole lung. Radiation therapy, precisely aimed, delivered high energy radiation to kill the cancer cells. It damages the genetic material, basically the DNA, and cancer cell will keep dying for days, even more months. So the radiation, if it can last in the lung or in any tissue actually, when you treat it, it can last for months. That could be the only treatment for some patients, as I mentioned, especially stereotactic radiosurgery. They have small tumors and they're not candidates for surgery. And you can give it during, before, or after chemotherapy. Most of the time now we combine it with chemotherapy. So what chemotherapy? These are the most commonly used agents: cisplatin, carboplatin, docetaxel, gemcitabine, nanoparticle albumin-bound paclitaxel. Paclitaxel is usually not water soluble, and it can make it hard for infusion if not, because it will be in camphor based. We have this technology where we can use a vehicle of nano particle albumin, put the paclitaxel inside it, and it will have better delivery. You can give it also faster infusion. And then you have pemetrexed, which is a form of antifolate therapy, but that we use it for the non-squamous cell. It does not work well for the squamous cell. And vinorelbine is another compound. In the 70s, researchers showed that treatment regimen like doxorubicin with cyclophosphamide, vincristine, and radiation therapy can cause significant tumor shrinkage in some patients with early stage small cell lung cancer also. So the combination of chemotherapy became, an option. In the mid-90s, there was a trial that compared 4 different doublets. Doublets meaning 2 drugs مع بعض of chemotherapy. Most of them had a platinum based. So you have cisplatin and paclitaxel, cisplatin with gemcitabine, with docetaxel or carbo and paclitaxel. As you can see, the curves are over each other, so it's almost all have the same efficacy. The median survival around maybe it was 10 months at that time, and then the mid-90s. 2000, the drug docetaxel or taxotere improved the overall survival when you use it for a second-line therapy. So they failed the first line, now use it as a second-line therapy. and that did improve the overall survival compared to basically doing nothing or no chemo. In the mid 2000s, we started talking about what we call adjuvant therapy. Adjuvant therapy means we do the surgery and then we give chemotherapy for maybe 3 months just to prevent the cancer from coming back. And there was a benefit in improving survival for those patients because unfortunately, even when you do the surgery, sometimes the cancer can still come back. So you want to try to prevent that. And that's when we have a couple of trials like the ANITA-1. Patients with stage 1B, 2, or 3A were randomized to no chemo versus chemotherapy with cisplatin, and the patient will get chemotherapy. As you can see here, mostly in stage 2, there was a separation of the curves. So patient with chemotherapy lived longer. In 2005, we added a medication called bevacizumab with the chemotherapy for stage 4 for non-squamous, non-small cell lung cancer that has spread outside the lung, which means stage 4. Bevacizumab is a monoclonal antibody. It attacks what we call the vascular endothelial growth factor. So basically, it kind of stops the cancer from making the blood vessels, also improves the delivery of chemotherapy to the cancer. So in combination with chemotherapy, it showed benefit and became kind of the standard of care for years. That's a study that showed carbotaxol plus minus Avastin, and you can see again the blue line with the Avastin, the yellow without it, and it improved the progression-free survival, which means the duration of when the cancer, when the patients have no progression, and the overall survival, and actually improved it to almost 12 months median overall survival versus 10 months. The hazard ratio was 0.79, which means it reduced mortality by 21%. And how we calculate this? The hazard ratio is 1 minus the hazard ratio is the percentage of mortality. So 1 minus 0.79 is 20.21. So it's basically you multiply by 100 is 21%. And then we have a trial with looking at stage 4 with pemetrexed cisplatin versus gemcitabine cisplatin. And in this trial, it was for non-small cell lung cancer. And those patients who had the pemetrexed did worse. You can see here the squamous part, like they have less progression-free survival if they got the pemetrexed 4.4 versus 5.5 months, and also the response rate was less. Response rate percentage was less. But this is when we realized that when you have a non-small cell lung cancer, it's very important to know what the type of histology is. It adeno, large cell, or squamous? Then the idea of maintenance came because in stage 4 we used to treat patients with chemotherapy وبعدين بنوقف, and we realized look, they still have cancer, so why do we stop? And then we decided, what, we need to do some form of maintenance. So pemetrexed and bevacizumab were 2 types of chemotherapy that we can do maintenance. We'll talk now about targeted therapy. So in the early 2000s, or actually in the 1990s, the recombinant DNA technology became common. We deciphered kind of the DNA. We looked at the genomics of the cancer cells. So we found that there's certain mutations that drive the cancer to grow. And if we can block those mutations or those abnormal factors, we can stop the cancer from growing. So the first drug in 2003 that was approved was gefitinib. It's an oral agent. It's a EGFR, epidermal growth factor receptor blocker, and it can shrink the tumor, and actually was compared those target therapy were compared with chemotherapy, and actually they work better than chemotherapy in those patients. How do we do molecular testing? We can do it through sequencing of the DNA. We can do allele specific testing, which basically analyze the DNA for a predefined abnormality, so we know what kind of what we're looking for. And the new thing is what we call next generation sequencing. We can also do FISH. Sometimes you can do immunohistochemistry to look for the protein target. The next generation sequencing now is becoming an easy technology, very well available now. It might take even like a week before you can the results, or even less, and you can actually look sometimes for 400 genes that way. So it's a fast technology, but you need tissue, and sometimes you need good biopsy for that. So we go, if we don't have tissue, In the past, we said no, tissue is the issue, but now tissue is not a big issue because we can do what we call liquid biopsies. Liquid biopsy means you take the blood sample and you look for what we call circulating tumor cells or circulating DNA of the cancer cells. And we know that lung cancer sheds that DNA. A lot of cancers do that. And then you can also look for the genes. You can actually have a sensitivity around 60 to 80%. And now it's getting better with the newer test. So that's a good test to order if you don't have tissue. And actually now the standard of care, we do it regardless. And even within the mutation, it can show you what variant of mutation, because we know that certain drugs can be resistant. Osimertinib is a EGFR tyrosine kinase inhibitor. We use it for EGFR mutated non-small cell lung cancer, very effective. And actually it works in patients who have a specific variant, T790M, which could be resistant to other oral agents. So it's not just like having the mutation, you have to look at the variant, because some variants could be resistant to certain medications. And that's why genomic testing is very important. And that's, like I mentioned, sometimes it's important to get a molecular biologist, because those help you in like understanding those testing and trying to figure out what is the best treatment. So what we so summary of EGFR mutations. So EGFR sensitizing mutations can predict higher response, progression-free survival. It's better quality of life. Imagine, instead of getting chemotherapy, having the side effect of chemotherapy, you're taking a pill. I mean, I have patients who've been taking, for instance, osimertinib for like 4 or 5 years. And if you see them, you can never tell they have cancer, and they kind of look great. And they're still in remission. So we can't do surgery for those patients, but you can give them oral medication, make it like a chronic disease. There are a lot of EGFR tyrosine kinase inhibitor, only 2 have been compared head-to-head, but now we have more that have been compared. Again, it's the specific mutation is very important. For instance, exon 20 insertions, those are resistant to most oral tyrosine kinase inhibitors. So we have some intravenous medication that we can use for those patients with the exon 20 mutations. So it's not just finding the EGFR, you have also to look for what type of mutation. And if the patient progresses, if they become resistant, we usually recommend the biopsy to see if they have a different mutation, but now we can do liquid biopsy. We don't have to do like a needle biopsy. Now, if the patient has those mutations, one of the treatment options we use for lung cancer is what we call immune therapy or checkpoint inhibitors. And those patients do not respond well if they have the EGFR mutation. The other common mutation, so the EGFR you can find around 12%, but the kind of second common one is the ALK gene rearrangement. It's mostly common in younger non-smokers, also have adenocarcinoma. Now, just want to mention something about the EGFR. The EGFR mutation mostly found in non-smokers and more in women of Asian descent, but you can find in women in general anyway. So the ALK is around 4%, and there are different also variants, and you do the testing through genomic testing, and we have at least 3 agents approved. We will have more, we keep having more. Every year we have 1 or 2 new agents approved for different mutations. So all the non-squamous non-small cell lung cancer should be tested for the ALK mutations. Those patients can have brain mets. Crizotinib is one of the best ones that we have out there. And there are other ones, second generation. Crizotinib was the first one. And we have other ones now. We have ceritinib and alectinib. Actually, alectinib is one of the best ones actually that are there, and especially if they're resistant to crizotinib. Those also can show activity with patients who have brain mets. This is just a slide to show you different mutations. You don't have to memorize them. This is just to show you how many, when we do genomic testing, how many genes we look for. We have the ALK, EGFR, MET, RET, vascular endothelial growth factor. We have the NTRK. And those are mostly have receptors in the membrane that activates other proteins or growth factors or tyrosine kinases that lead to DNA transcription of specific proteins that lead to the cell survival and prevent it from dying. So we try to find which one is the mutated, find the driver mutation, and then try to block it. So it shows you like different medications that can help block those mutations. Now, this is why it's very important, especially in the adenocarcinoma type. Remember, we said that adenocarcinoma is now the most common type of non-small cell lung cancer, and we look for biomarkers. So these the pie chart. So for lung cancer, we have 85% non-small cell, 15 small cell. In the non-small cell, around 50% adenocarcinoma, 40% squamous, and 10% large cell. And now we have all these different mutations, the EGFR, which is the most common. We have RAS, KRAS, ALK, RET, HER2, BRAF, MET, NTRK. All of these, we have medication that can block and stop the cancer from growing. This table here actually shows you the molecular alteration in non-small cell lung cancer. For instance, the EGFR mutation exon 19 and 21, those are sensitive to oral medications. Remember, me mentioned exon 20 is not sensitive to oral medications, so there are there is an intravenous medicine that we use for that. The EGFR, usually you find it in young patients, usually females, never smokers. Then you have the ALK, and you have the ML4 ALK variant, younger patient, again, non-smokers. Adenocarcinoma, those usually aggressive tumors, they can go to the brain. Then you have ROS1, female, younger patient, non-smokers. You have the KRAS, so you have different mutation. The KRAS, you have mutation codon 12 and 13, and we have at least 2 drugs now, and more will be coming for mutation, for instance, in the G12C variant. Those are usually older patients, they're smoker, those are more aggressive, they have poor prognosis, and now with the newer agent, they do respond, but I mean, they can still, the response may not last too long. Then you have BRAF mutations. The most common is V600E in females. There are other variants in males. Usually those are smokers, those are aggressive tumors, and we usually treat them with BRAF inhibitors. Sometimes we add MEK inhibitors for those patients, MEK inhibitors. Then you have the HER2, which is mutation exon 18, 21, or amplification. They can have amplification, unnecessary mutation. That's the human epidermal receptor. The mutation, you can find them in females who are never smokers, and amplifications in males and ex-smokers. MET mutation exon 14, you also can have amplification, and we also have oral agents that can target those. This is a table that show you like almost 70% non-small cell lung cancer, you can have druggable mutations, and for each mutation here, it shows you what medication we can use. Different oral regimens, most of those are actually oral agents. The HER2 mutation amplification, the FAM trastuzumab deruxtecan is actually an intravenous. It's a monoclonal antibody that has a payload of chemotherapy attached to it. It targets the HER2 and then it delivers the chemotherapy there. KRAS, for instance, we have those 2 drugs, sotorasib, adagrasib. The MET exon, we have at least 4 drugs that target that. The RET inhibitors, we have 3 drugs. So each of those mutations, we have more than one option that we can treat the lung cancer with. So that's why it's important to do molecular testing, because you want to try to find what is the driver mutation and try to treat the patient. And even if they progress, you can repeat that test through liquid biopsy to see if the mutation changed or another mutation have shown. Because, you know, the cancer keeps mutating, so you can change the treatment. We'll talk a little bit about immune therapy now. Immune therapy, basically, to explain what immune therapy is, our immune system has what we call check points. If the immune system gets activated, like if you have an infection, inflammation, you get activation of the immune system. So that's what causes the fever, the chills. After the infection is controlled, then the cell the immune system is suppressed. There is the PD-1, for instance, is one receptor that gets activated, so it kind of slows down the immune system. Now, unfortunately, in cancer, the cancer can deceive the immune system, and it will stimulate the PD-L1. So this way, it will deactivate the immune system, like deactivate the T cell. If we can find a medication that can block this here, so this way you don't you can break that bond here, and this way you can activate the T cell again, and this attacks the immune system. So we can actually look for the PD-L1 expression in the cancer cells through immunohistochemistry, and the hard expression that kind of predicts, one of the ways to predict the response to the immune therapy. The unique thing about immune therapy, when it works very well, and it can work for a long period of time. The problem is sometimes the immune system gets activated to an extent that it can attack its own cells. So if it attacks the lungs, and we'll talk about this a little bit, but it attacks the lung, you can have shortness of breath, bowels, diarrhea, or colitis. So patients who have autoimmune disease already, like rheumatoid arthritis, ulcerative colitis, psoriasis, those diseases can actually get activated and can cause harm. So some of those patients, unfortunately, cannot get the immune therapy. So what we look for is the PD-L1 programmed ligand 1, which actually expresses 60% of non-small cell lung cancer cells. And this shows you the adenocarcinoma around 40%, squamous 40%. This is the less than 1% expression, but 1 to 49% around 30 to 40%, and then more than 50% in 1/4 in most lung cancers. And again, the higher the expression, the more likely, it's not guaranteed, but the more likely that the patient would respond to the immune therapy. So what do we use immune therapy? We use it now either by itself or in combination with other immune therapy, different target, or with chemotherapy. So for instance, in patients who have high disease burden and PD-L1 negative, we give combination chemoimmune therapy. They have synergy. They work well together, like 1 + 1 = 5. Now, if the PD-L1 goes down, like 1 to 49, towards, so that's the ones here, like we give chemoimmune therapy with high disease burden. Now, PD-L1 goes up more than 50%, frail patient cannot tolerate chemotherapy. We can just give immune therapy by itself. We can give it like as one drug, or we can give 2 drugs. Some combination, we give like 2 cycles of chemotherapy with immune therapy, and then we continue with immune therapy. So this is very important. Like we have to check that. So 2 things you do when you have lung cancer patient in advanced stage. You check the molecular testing to look for mutations like the EGFR, ALK1, RAS, and also you look for the PD-L1 expression, because that can help you to decide like how do you treat lung cancer. There are actually now more testing, like there's a proteomic test that actually can predict the response to immune therapy also through looking different expressions of proteins. This is the immune therapy associated side effects. Again, the easy way to remember it is like it can attack any organ, just add the word itis. So if it attacks the brain, you can have cerebritis, encephalitis, Guillain-Barré syndrome. You can have uveitis, you can have thyroiditis, endocarditis, myocarditis, pericarditis, pneumonitis, hepatitis, vasculitis, pancreatitis, and you can have diabetes, colitis. So the most common ones are the colitis and the pneumonitis, and those are the most serious ones because they can kill the patient. I even have patients who have pancytopenia, like leukopenia or anemia, that is autoimmune related. So the symptoms are usually related to the organ, and the treatment can be easy. If they have thyroiditis, which can lead to hypothyroidism, or diabetes, you can just replace the treatment, right? Give insulin, give thyroid therapy, but otherwise you can give steroids or give immune suppressive therapy. So you activated the immune system, so you try to suppress it now. So in general, you hold the medication, you treat the symptoms like diarrhea, you have antidiarrheal agent, oxygen for breathing, things like that, thyroid replacement therapy, insulin, and steroids, mostly in grade 2. Those are very important. Give steroids, you can save lives. And this is when you have pharmacists, nurse navigators, if you have them available, because then they can help the patient. And you have to educate the patient, tell them if you have any of those symptoms to call right away, because those symptoms can be deceiving. That you can think something different. You can take a patient have pneumonia with shortness of breath, give them antibiotic, that's not going to help. You have to give them steroids. Of course, you have to rule out infectious diseases. You can't assume that these are all related to those medications. I want to talk a little bit at what we call antibody-drug conjugates. Those are medications where you can have monoclonal antibody here. You can combine it with a chemotherapy. The monoclonal antibody binds to a receptor, and then it get engulfed into the cell, and then it releases what we call the payload. It's as if انت عم بتوصل يعني قنبلة للcancer cells, the chemotherapy. So you use a monoclonal antibody because it's designed to attach to certain receptors that are present in the cancer cells, and then when the cancer cells takes it in, then it releases the chemotherapy, and the chemotherapy kills the cancer cell. And sometimes it gets released after it kills the cancer cell and kill cells next to it, so it can has also the killing effect to the cells in next to the area, the adjacent cells. These are not yet prime time in lung cancer. They've been used in other cancers, except for the HER2 deruxtecan, which is anti-HER2 therapy. We still use it in patients who have HER expression in the cancer cells. But it's becoming, it's in research now. There's another one that we use for small cell lung cancer. So now it's in research, and it seems it's gonna be one of the forms of therapy for those patients. I want to talk a little bit about neoadjuvant and adjuvant therapy. So neoadjuvant means that we do it before surgery, and adjuvant after surgery. We can use now chemotherapy with combination immune therapy, that becoming new standard of care. So you give 2 or 3 cycles of chemotherapy with immune therapy, then you go for surgery. And then if they have good response, you continue with immune therapy alone for maintenance. And there are different combination of drugs that you can use. Sometimes you use just chemotherapy after surgery. Sometimes we use just immune therapy after surgery, or we do chemotherapy then followed by immune therapy. We do it like for a year. And now for the EGFR and ALK mutations, we can even use oral treatment after surgery. So osimertinib, the drug I talked about before for EGFR, it is actually approved in the United States after surgery to be given for patients who have the EGFR mutation. So now the molecular testing is also important to look for in patients who are not stage 4. So initially we only focus on stage 4, but now even in earlier stages that are going for surgery, it's important to look for the PD expression and also do molecular testing to see if they have any mutations. It's becoming now new standard of care. So you do the surgery and then you take a pill for a couple of years, 2 or 3 years, just to make sure the cancer doesn't come back. Because that's a problem with lung cancer. You know, it's even at the early stages, some patients, they can still have the cancer come back. And they are working on tests. There are tests that you can do like on the cancer cells, and they can predict if the cancer can come back or not, regardless of the stage. Because now we're understanding that biology could be more important than the size of the tumor or the involvement of lymph nodes. But, you know, this is still in progress. The more we understand how the cancer works, and the more we understand, like, you know, what proteins make it more aggressive, what proteins makes it less aggressive or indolent, what drivers like drive the cancer to grow and to be aggressive, and then we can find ways to block those drivers or enhance the immune system to fight the cancer, combine that with chemotherapy. This way we improve the outcome, have better quality of life in treating lung cancer. So now, actually, if you remember, I said when we had that combination chemotherapy in the mid-90s, the median survival was around 10 months. Now we're talking about like almost 30 months, so it's almost tripled in around like 25 to 30 years, and it keeps improving. It's not uncommon now to see patients with lung cancer who, if you see them in the street, you can never tell they have cancer. They take oral medication or immune therapy every 6 weeks. And they look like normal people. Not that cancer patient not normal, but like, you know what I mean, like people who are healthy. So I will stop here. I hope this was helpful regarding like cancer in general, like an overview. It's could be more complicated than that, but I just wanted to give you an overview about like how we started treatment and what we're going through. If you want to remember anything, really like how it evolved. Earlier stages, we do surgery if we can, because that's the ultimate cure. And if patients who are not surgical candidates or more advanced stages, we can do chemoradiotherapy or we can do systemic therapy, and that depends on the type of cancer and the genomic profiling of the cancer, PD-1 expression. So you can do chemoimmunotherapy, you can do just targeted therapy, you can do just immune therapy, different mutation. Now for small cell lung cancer, still the same treatment over 40 years. We treated if it's what we call limited stage with chemoradiation, followed now becoming new standard of care with immune therapy for at least a year. But if it's extensive stage, which means it's outside the lung area or the thorax for the field of radiation, then you do systemic chemotherapy with immune therapy. And we try to do prophylactic brain radiation because it's almost guaranteed that it will metastasize to the brain. The future is bright when it comes to lung cancer. Definitely early screening to find early stage is still the curative way to do it. So patients who are smokers, 55 to 77, or even sometimes you stretch it to 80. CAT scan, low dose CT CAT scan of the lung can help find smaller nodules, and then they can get them at earlier stages. And I end it with a picture from my hometown, Maen, Qada Nablus. Thank you very much again. My email is in the first slide, just in case you don't remember. It's mhussein@flcancer.com, mhussein@flcancer.com. I'll be happy to answer any questions. Allah yuwaffiqkum, inshallah.